that we are able to host this program today. For those of you not familiar with the Perlmutter Cancer Center, I just wanted to give a quick background on it and our recently launched LGBTQ Cancer Prevention and Treatment Initiative. So we have been designated a comprehensive cancer center by the National Cancer Institute, which is the highest level of designation that a cancer center is able to attain. We have specialists in Manhattan, Brooklyn, Queens, and Long Island. And in 2020, we launched our LGBTQ plus Cancer Prevention and Treatment Initiative. So the initiative has 3 goals. The first is to make sure we are providing clinically appropriate, inclusive, and sensitive care for our LGBTQ patients. The second goal is that we want to make sure that we're building this initiative in partnership with the community and developing partnerships with community-based agencies like GMHC. And the third goal is that we want to advance cancer research for LGBTQ populations. So this is our first event where we've partnered with a community member, and I'm very grateful for this partnership with GMHC, but also for the long history of wonderful work that GMHC has done. Dr. Shelley is a tenured professor of global public health in the NYU School of Global Public Health in the Department of Policy and Public Health Management. She is founding director of the school's Global Center for Implementation Science and is co-director of the Epidemiology and Cancer Control Program at the Perlmutter Cancer Center. Dr. Shelley's work is motivated by a deep commitment to reducing tobacco-related disparities in morbidity and mortality in the U.S. and Vietnam. In pursuit of this goal, Dr. Shelley has built a rigorous program of translational, population-based, and policy-relevant research to optimize implementation of tobacco use treatment in healthcare delivery systems, accelerate implementation of tobacco control policies, and to develop innovative ways to improve access to and treatment of nicotine addiction among people with comorbid conditions. So thank you for joining us, Dr. Shelley. I'm going to turn it over to you.
Thanks. So I guess it's going to be, are you taping this, Rachel?
Yes, this is being recorded and it'll be on our YouTube page. So
okay.
For anyone who wasn't able to make it today, they can view it after. Yeah. Okay,
well, I'll go ahead. More folks will come on board, but thanks, Paul, for attending. So, you know, I guess I was told that this is really for smokers, this talk. And so I oriented it to that by starting with this title, Quitting is Hard, but You Can Do It, which is true. Okay, what's wrong? Why can't I go? Oh, so, you know, I don't need to tell this group that, you know, this population, LGBTQ, have higher smoking rates than the general population. And this is data from 2017 from the City Health Department. So it's a little old, but still not that different. And the reason is, you know, because of discrimination and stigma, victimization, higher rates of mental health conditions, and other factors that are associated with higher smoking rates like homelessness and HIV, we continue to see these high rates. It also doesn't help when your peer group has high smoking rates. And so it becomes sort of a self-fulfilling issue where it's harder to quit when more of your colleagues and your friends and your social circle are smoking. Also, the tobacco industry had targeted, and they probably still are targeting this population, but good news is that we have some counter advertising that's going on in this community, targeting, you know, sort of countering the tobacco industry's work. And you see here some examples of that with the TIPS campaign on the upper left from the CDC that is doing this amazing campaign, creating these packets about, can you mute if you're not muted, about real people stories about quitting. And this one is actually an HIV positive smoker making an important case for quitting. So we all know that smoking is leads to, the cigarette when you inhale, the smoke contains almost 7,000 chemicals, with over 70 causing cancer. And that's why smoking negatively impacts nearly every organ in your body. And the red items are just newer information based on the last Surgeon General's report. So it's hard to escape the impacts of long-term smoking. Quitting, though, at any age, importantly, increases survival, but quitting at a younger age provides the largest gain. And I showed this complicated slide just because I think it's worth explaining that if you look on the left, this is a really important point, that the younger you quit, the more gain you get. So if you quit between 25 and 34, you gain 10 years of life. And in fact, by the time you're 40, you have the risk of a never smoker of all the horrible smoking related illnesses. So you get back to normal, essentially. If it's 35 to 44, you lose that extra, you get 9 years. And as you see the dotted line moving closer to the current smoker curve, the longer you wait, the less years gained, although you continue to gain years. Even if you quit at 70 or 80, you gain about a year or two as well. So the message here is quit now, quit soon. And even if you've been smoking a long time, not only are there, long-term effects though, but the reason to quit as you're getting older, if you haven't quit already, is because the health benefits are immediate. So within 20 minutes, your blood pressure is down. Within a year, your risk of a heart attack is halved. Your taste and smell improves. Your breathing is better by 3 days. And so these are real benefits that make smokers feel better almost immediately. There's obviously the financial cost of smoking as well. In New York City, a pack is probably more than $13 now, unless you're buying illegal cigarettes, which we won't talk about here. But most smokers think about this as a pack at a time of $13, which doesn't seem so bad. But it's important to sort of, as you're trying to quit, give yourself as much motivation as possible. If you take that number out to a year or 2 years, you start to see how big an impact it is on your budget. So quitting tobacco use is a two-pronged issue. It is both a behavioral dependence and a physiological dependence, that being a nicotine addiction. And it's important to note that, because that's why combination counseling and medication to treat the physiological addiction and the behavioral component are the most effective ways to quit. So attacking both of these is critical. So thinking about this from a stages of change approach, basically this is a chronic relapsing illness, and we have to acknowledge that, because it can take many times for people to quit. And that's okay, that's normal, because the more times you try, the more likely it is you will succeed. And so it's mainly, these are some of the stages that people go through, and they move through them, all the time. They may not want to quit, or they're thinking about quitting, and then they're actually preparing, ready to quit. They're taking action. They're not smoking anymore because they're getting counseling, getting treatment. And at 6 months, they're actually haven't smoked since they quit. And we call those folks people who are sort of non-smokers at that point, because relapse rates are very low at that point. But there are lots of reasons why people relapse. Relapse is very common in a chronic relapsing illness, like any addiction. And then the cycle comes again. It can be, sort of discouraging, but it is, a process. And this is, sort of part of the process that smokers will recognize they've gone through multiple times. So how do we break that relapse pattern? First, before I talk about that, I just want to point out, talk about the physiologic component of the two-pronged issue. And, most people know that the data show that nicotine can be as addictive as heroin, cocaine, or alcohol. So that's why it's so hard to quit. It's not the cause of long-term disease. That's a a myth that unfortunately is held not only by smokers still, but by some doctors, which prevents people from wanting to use nicotine replacement therapy. So I just want to make sure that that's clear. And something else important is that, why is it so addictive? Well, it has to do with the fact that nicotine, when you inhale on your cigarette, reaches your brain in 7 seconds. What does that mean? So when you inhale through your lungs, within 7 seconds, nicotine is binding to your receptors in your brain and releasing dopamine, which we know is the reward pathway of most drugs. So you're feeling really great. You're getting that nicotine buzz. And then very quickly, those levels drop because it is a very short half-life. And that's a setup for an addictive drug. Quickly active, but doesn't hang around very long. And it creates this cycle of creating this addictive sort of cycle where if you don't get it, continue to replace the nicotine quickly and rapidly and frequently, you start to feel withdrawal symptoms. And these are the symptoms, and you may recognize them if you've tried to quit. They can be mistaken for other physical mental health issues. Very important to know that these can continue when you're trying to quit. That oftentimes the doctor will say, oh, just take, medication for a few days, that'll be fine. But if you stop taking, for example, if you're taking medication to prevent withdrawal symptoms, then, if you stop taking those medication within a week, you're still in that space of that time where you're going to fall back into feeling significant withdrawal symptoms and cravings and probably relapse. So the idea is if to address withdrawal symptoms, it's not just taking medication to help with that, but taking it long term for at least 3 months so that you get past that peak time when symptoms of withdrawal are at their worst. So what helps people stop? And this is just an arrow showing how you can go from cold turkey, which is the least effective. And most people who try and go to cold turkey will relapse within 24 hours. Because when you wake up in the morning after not smoking all the evening, you're already feeling in withdrawal. Up to the top, which is a combination of counseling and multiple medication, means in terms of what do I mean by multiple medications? So sticking with the nicotine addiction component of the two-pronged problem, there are 7 FDA-approved medications, over-the-counter gum, lozenge, and patch, and most smokers have tried to quit. And so many of them, if they've tried to quit, have used the gum or the patch, which were the earliest ones that were approved. The 3 asterisks are to say that these are over the counter, except if you want them for free and you have Medicaid, you do need a prescription. And, an unfortunate barrier, but the good news is Medicaid does cover all 7, and you can have more than one, which is really the way that needs to be prescribed, because the patch combined with the short-acting gum and lozenge is much more effective than any of those alone. So I always, unless someone's smoking less than 10 cigarettes a day, prescribe combination patch and a lozenge or patch and a gum, and I'll talk about some of the other prescription drugs. But if you're just using nicotine, that's a strong recommendation. And so the medications, are free under Medicaid. Require a prescription spray, I'm not going to talk about because I don't prescribe it. It has a lot of side effects. But the inhaler is an interesting product that's underutilized, and I'm using it more because of e-cigarettes. And that's because patients, sort of go to an e-cigarette because it's the closest thing to smoking, because you get that ritual, that hand-mouth ritual. And the inhaler, you see that little white sort of cigarette-looking like thing on the right. In the picture, you put a cartridge in there and you puff on it for about 80 times or 20 minutes, and you get the full dose of the cartridge, which is like chewing a piece of gum or a lozenge or a cigarette. And you use that, every 2 to 3 hours, depending on how many cigarettes you smoke a day. Again, heavy smokers like that, but I don't use it alone. Again, if you're smoking more than 10 cigarettes a day, I would combine that with a patch. So the inhaler, the gum, lozenge are all short acting, meaning they act quickly, but then they disappear quickly, which means you need to constantly redose. The most common reason why people, quote unquote, fail these drugs is they underutilize them. They don't take them often enough. You need to take them on a regular basis because it takes 15 minutes for these short acting ones to act. And so by the time you wait till you're in withdrawal, you're going to have to wait 15 minutes until they start acting. So I really recommend using proactively, set up a schedule where you using these every 2 to 3 hours, depending on your withdrawal symptoms. And then there's bupropion, which is the only antidepressant approved for smoking cessation, and it's much more effective if used with the patch or the lozenge or the gum or inhaler, one of the nicotine replacements. And then Chantix, which is probably the most effective treatment on the market, but not recommended to be combined with anything else. All of these actually have, one of the main side effects is insomnia, but I have not really had people stop the drug because of that. Just to sort of make this point about gum and lozenge is that, most of the time people who fail these medication or say they, one of the reasons they say it doesn't work is because they're not getting the nicotine, actually, because gum isn't chewed like gum and lozenge should not be chomped on. Is you chew it, peppery taste means that the nicotine's being released. You park it between your gum and your cheek so that the nicotine's absorbed into your cheek. And then you chew again and park, chew, park, chew, park. to keep releasing the nicotine. If you don't do that, or if you chew the lozenge, all that nicotine is getting absorbed into your belly. So you not only continue to have withdrawal symptoms, but you feel pretty sick. It causes upset stomach and nausea. And so I'm just, I'd like to show this slide just to make sure people know that this is really important to use these products appropriately. You can use these products forever. I have friends who've been using gum for 30 years. These are over-the-counter medications. They're safe. I think we use them not long enough. As I said, 3 months minimum. But we know now that if you use it for 6 months, these medications, including varenicline, you get an even higher quit rates, likelihood of quitting. And so use it until you feel confident enough to stop. But the truth is, again, withdrawal symptoms should be sort of going away by a month, 2 months, but many times they do last for several months. And so that's recommendation for that. If you slip while you're smoking, keep going. Keep using your patch. Don't pull the patch off. That's a common mistake. Just get back on track. The FDA has actually changed the recommendation and said that it's not dangerous actually to smoke and use these medications, although I don't recommend it. But it's not if you slip, it's not a reason to stop using the medication. Smokers really know when they feel like they're using too much nicotine. They're the best at titrating the amount of nicotine in their blood, and so they'll reduce either smoking or they'll reduce their lozenge and patch or gum. So it's okay. Just if you stop using the medication, you will relapse. I talked about this using them at the same time. So what about the behavioral component here? This is a really important picture, and it's basically what we call a track pack. And I ask all of my patients who are trying to quit to fill this out. To try and fill it out at least for 2 to 3 days, if not more. And this is a very detailed one. You can create one with a couple of boxes, basically saying time of, which cigarette this is, and the time of day, and what you were doing. You were eating, you were relaxing, you were working, what your mood was, and how much you really needed that cigarette. And what this does is creates this map for you to see where your triggers are, what time of day you're smoking, and how much you really need the cigarette. Because the ones that really you didn't need it, but you kind of did it because you were bored or sort of knee-jerk, always smoke that cigarette, that's really important to know, because you can actually start to reduce before you quit by getting rid of the least needy, the ones you need the least. Mapping this out really increases people's ability to then develop coping strategies and anticipate when they're going to be in high-risk situations and start to kind of create their quit plan. This gets to this idea of this trigger to smoke. And in between are these thoughts, feelings, and moods, which is why, sort of showing this, like, what are you doing? What are you feeling is the most important thing. And the idea with behavioral counseling is that you work through this issue of how do you change your thoughts when a trigger happens? How do you address it differently? What are you going to do? What are your coping strategies going to be to address negative thoughts, feelings, and moods to basically stop that pathway? Other behavioral strategies, meditation, mindfulness, yoga, deep breathing, the 5 Ds, building a support system, and developing a quit plan are all other ideas. And I'm going to show you some resources where you can go online and go to online apps and specific LGBTQ resources that sort of, again, take these behavioral strategies, help you sort of use some of these strategies to stay on track. How do you access medication? So if you're in New York City or state, Medicaid, as I said, Medicare also covers prescription medications. Over the counter is at the will of the managed care plans. Private employer-based insurance, generally, they don't cover the over the counter, but they generally do cover Zyban and Chantix. And there's, discount cards, and I'm sure GMHC has some information about this kind of, access to medications. New York State and city often run these free nicotine gum programs. If you keep on, at their website and just keep track of this, it's really important. And maybe, GMHC can keep their eyes open for this. It's a great resource, and they do it probably every 6 months, sometimes every 3 months, depending on the funding. What about counseling? Well, we have a Quitline, pretty, vanilla though. It's not, geared towards LGBTQ populations, but it does offer 2 weeks free of NRT and free counseling. And this is the number. You can call the 311 number and they do connect you. The website also has other kind of information. This is a really cool opportunity. This is a government sponsored program, and it's actually a really nice website, and you can sign up very easily for text messages. And I've had my patients sign up for these text message programs as just a supplement to whatever else they're trying to do. So if you're on medication and you don't really want to join an online counseling, you can sign up for text messaging. They have now these specialty sort of subgroup focus. They don't have LGBT yet. So the smokefree.gov one generally could be helpful. I see this as more sort of supportive than sort of the one thing that may, do it. If you're doing other things, it can be a great reminder to get these messages. I did sign up for it, and I actually thought it was interesting, even though I wasn't trying to quit. But it was actually helpful, and you can manage it in terms of how often you get those messages. So another resource, and this is how you sign up. It's really simple. You just go to the website and put your telephone number in. If your youth are vaping and they want to quit, and vaping, I'm going to talk about in a second, is quite addictive. I mean, Juul, which is what the kids were using, is one of those little pods is equal to a pack of cigarettes. And since vaping you could do in your house without your parents knowing, kids were getting, the addiction rate was incredibly high for these products. So the Truth Initiative has developed a text message program to help young people and young adults who want to quit vaping try this. I've helped my patients quit vaping by using actually the same thing we use for cigarettes, which is nicotine replacement therapy, to try and get people off vaping if they don't want to be on it, that is. So I just want to, again, this slides will be available to you, but the city has an app called Help Me Quit that you can download for free on on the Apple App site. And they have a map, search health map on the nyc.gov for cessation programs website to get a map of smoking cessation programs around the city. And this is just a series of LGBT resources. This LGBT Health Link, which you may know about, has some very nice specific LGBTQ oriented smoking cessation resources as well. And then there's this website called becomeanx.org, colleagues of ours who used to be at Truth developed, and it's actually been studied and shown to be effective. But again, it's not geared specifically to LGBTQ populations, but another resource. And again, we'll share all this with you I assume Rachel and Megan will. What about e-cigarettes? So they come in lots of forms, and I would be remiss in not bringing them up. The issue is, I'm going to talk about the dangers, but I'm also going to talk about the potential benefits for smokers. So the real concern is about the non-smoker using this product, because when kids and non-smokers start using it, they're going to become addicted to nicotine, and for no reason. Smokers are already addicted to nicotine, but now you're creating a whole new generation, or of young adults who are becoming addicted to nicotine. That's bad news, and that's reason alone for this to be a problematic product. But there are also other things, glycol mist and other chemicals inside the vape that you're inhaling that could be, have long-term effects. You see these different products, and one of the issues has been the Valley scare, which was the e-cigarette lung, inflammation that was killing young people who were using that. That was specifically related to this vitamin E acetate that was in this liquid that was primarily in the THC liquids, the liquids that were not containing just, about nicotine, but actually THC. And so that sort of epidemic has declined and almost disappeared because of the information we have. But it's not safe to use to go to get juices and liquids for these products that you don't know the supplier, that you don't know a reputable supplier. These vaping stores are now licensed by the city. And so you should only buy e-cigarette products from a licensed e-cigarette seller. And what do I want to say about vaping in general for smokers? And I don't have a slide on this, so I'll stay on this slide, but that I'm in the business of helping people quit. So from my perspective, if you're a smoker and you really want to use an e-cigarette, I will support you because it's a form of harm reduction. We know from the UK and even Canada, who think we're pretty puritanical about these things, they actually include e-cigarettes in their formulary. The UK did an incredible report that suggested that e-cigarettes were 90% safer than cigarettes. And so if you're a smoker and you want to reduce harm, there's no question that using e-cigarettes is less harmful than smoking cigarettes. And there is actually some evidence that they're as effective in helping people quit as nicotine replacement therapy, but very few studies have been done, so I can't say that for sure. But I do believe from the literature and from the UK report and the work coming out of Canada and Australia that that this is a harm reduction approach, which is not something that's popular in tobacco control, but is real. On the other hand, again, if you're a non-smoker, there is no reason at all to put yourself at risk of becoming addicted to nicotine, as well as increasing harm to your lungs and your health. So these are two very different populations when we talk about the risk, of this issue. And finally, I think, this is my last slide. And then I was going to sort of try and get Q&A, but I don't know how many people sign up because I can't see. But, to be complete, I wanted to talk about COVID-19. And smoking doesn't increase your risk of getting COVID. But it does increase your risk of severe illness from COVID, not surprisingly, because it's already harming your lungs and increasing your risk of thrombosis and clotting, which is COVID, one of the most dangerous side effects of implications of COVID. Vaping it's less clear. It may increase your risk of severe illness, but it's still being studied. But importantly, sharing these products, hookah, pipes, other tobacco or cannabis products, can spread infection. Being near someone who is using these products also increases it because they're not wearing a mask. I realize I didn't talk about hookah and other products, but hookah is just, the CDC's put out some data that shows if you're a heavy hookah user, your risk is sort of almost equal to that of a cigarette smoker, or a pack-a-day cigarette smoker. But that being said, if you needed another reason to quit, in this context of COVID, there was that added benefit. Unfortunately, the stress that this pandemic has caused has actually, we've seen not an increase in smoking, but fewer quitting. So we had seen a consistent drop nationwide in New York City of decrease of smoking prevalence. And over the last year, that has basically it's zeroed out. And we think that this has been, just obviously it's an overwhelming stress for everybody in the U.S. And smokers are no different. And since smokers have spent, sort of the last 20 years or so using smoking as a way of reducing stress, that is their coping mechanism. So not surprisingly, they would kind of continue to smoke and have trouble quitting. But it is no time like now to actually try and quit. So I'm going to just kind of stop sharing my slides and just see if anybody has questions for me. I went through that pretty quickly, mainly I really wanted to leave time for Q&A. So whatever questions you have, I'm happy to answer based on anything I talked about or anything else I forgot to talk about. Can I ask you a question, Paul? If you can, I don't know if you'll be able to talk. What are you doing at GMHC related to smoking cessation? Because we have a contract with the state health department, and one of our goals is to actually work with your group and others in this community to try and help, with resources and increased quit rates among the population that the organization serves.
I know Paul was having some audio issues. Let's see if he can. Paul, are you able to hear us?
I can hear you. Can you hear me?
Yeah.
So to my knowledge, I'm sorry, I'm still had the echo. I'll have to.
I don't think everybody's muted, so if everybody could mute, if you're not talking, that would be great.
Okay, I know Paul is still hearing the echo. So just a reminder, if anyone has a question, there's a question box in the bottom right-hand corner. Dr. Shelley, we do have one question here for you. How does being near someone who is smoking or vaping increase risk of COVID-19 exposure? Does this also increase risk of severe illness?
So the idea really of the being near someone smoking is that when, in this time of risk of getting COVID, is that they're not wearing a mask and they're next to you and they're breathing out, they're blowing out. And we, there have been cases of some of these, outbreaks. Actually, there was an interesting one among this choral group from singing next to each other. And so there's like increased evidence that in situations where someone's blowing or singing or coughing, obviously, near you, and masks are very important, but they're not 100% depending on the kind of mask you're wearing. So that in itself can increase the risk of transmission. If you're around someone who's smoking. Obviously, I didn't talk about secondhand smoke. I did have a slide on that, but the data is really strong. I mean, secondhand smoke is a Class A carcinogen, and established by the EPA that fact, 30, 40 years ago. And so exposure, it's why we have no smoke-free housing policies, why we have smoke-free restaurant policies, because literally, restaurant workers were getting sick from being exposed to cigarette smoke, including, bronchial problems. And that data came originally, interestingly, from the airline industry, where airline stewardesses were actually put to class action suit because they had increased risk of lung cancer. And it was tracked directly to being exposed all the time to the plane, inside of the plane, where they were exposed to dense amounts of smoke. And that's true, obviously, if you live with a smoker. What smokers also don't, oftentimes try and diminish. I mean, I've treated smokers for a long time, and they'll say to me, well, I smoke in the bathroom and I blow out the window. But we know that smoke gets into the rest of the house. And there's even some really amazing data from the CDC that actually, if you live next to a home that's an apartment, especially multi-unit, I'm talking about multi-unit housing, which is what we live in New York City, they did this study in the CDC where they had a nicotine monitor in a non-smoker's apartment and one in the smoker's apartment next door. And every time that smoker smoked, the nicotine levels went up in the non-smoker's apartment. Not as high, obviously, but significantly. And so we live in each other's homes, essentially, which is where the non-smoking, the smoke-free housing movement, sort of has risen in relation to that data too. So yes, secondhand smoke exposure can cause asthma among kids, ear infections, respiratory infections, and even if you live with a smoker, increase your risk of lung cancer, COPD, cardiovascular disease.
Dr. Shelley, this is Megan. I have a question. So I know sometimes smokers will report that they are afraid of weight gain if they stop smoking. And I'm curious if that's what your response is to somebody who brings that up.
It's a great question. I really try not to diminish that because I'd be lying to smokers. So I said, oh, don't worry about that. It's not going to happen. The problem is, this is why I get so aggravated when young women start smoking, because ultimately, they care so much about their weight, but they're creating a weight problem for themselves when they try and quit. And so nicotine actually not only depresses appetite, but in itself actually can increase metabolism and so decrease weight gain. So when you stop using nicotine, first of all, your appetite is increased. So what I do is I try and say, yes, I mean, generally though, it's maybe 5 to 10 pounds. It's not 30 pounds, although smokers do sometimes gain that much weight. But that it's really not 30 pounds. It's 5 to 10 pounds, but you can prevent that. There have been studies that showed how you can. And one of the ways you can, first of all, is to use nicotine gum, lozenge, or the inhaler as one of your quitting methods, because those are actually associated with not having immediate weight gain, to putting off weight gain. And it probably has to do with, having something in your mouth. So one of the things I do recommend is, having healthy snacks, either sugar-free sucking candies or carrots or cinnamon sticks or things to put in your mouth so that that oral, sort of craving that smokers get is satisfied with something that's not going to, have to gain weight. It gets back to this issue of planning. You really have to plan. It's like any behavior change. And so planning to have those kinds of snacks with you, drinking a lot of water, and using those medications, if you're really concerned about it, at least can put it off so you're not sort of worried about that at the same time you're trying to quit. What we really don't recommend is going on a diet while you're trying to quit. There's actually been some really interesting studies on that show that people who try and diet, there was this 3-arm study, people who tried to diet and quit versus people who actually gained more weight and were less likely to quit. But people who tried to quit and exercised and increased their exercise regimen while they were trying to quit actually had higher rates of quitting and less weight gain. So, a lot of smokers don't exercise. And I'm not saying, if you're 55 years old and you're quitting smoking and you have not exercised in 5 years to sort of start running, but people underestimate the value of 30-minute walks every day. And so if you start quitting using, some of the medications I said, gum, lozenge, inhaler, or an e-cigarette, and you start to a regular exercise regimen, and you try and plan to have snacks with you that are healthy, that keep your mouth active, those are some of the things that seem to work to put off or prevent weight gain.
Dr. Shelley, we have another question here. What should we know about the risks involved with secondhand smoke? It's difficult to avoid being next to a smoker. With that said, how much exposure is considered risky?
Yeah, I guess I didn't answer that in my last response. So I'll try again to kind of be more specific. So the risk is higher with more intensity. So if you're in a restaurant, you go into a restaurant and someone was smoking in a restaurant, which won't happen in New York right now, fortunately, and you are relatively healthy, that exposure is probably not going to increase your risk of disease. It's consistent, regular exposure. So living with a smoker, working in a place that allows smoking, that's the kind of exposure that increases the risk of the disease, the chronic diseases that I mentioned. Including, a kid though. So there is evidence though that a child or anybody with asthma who is briefly exposed could actually trigger an asthma attack. So that's a different thing. That's an acute reaction to exposure to smoke. But the long-term more chronic diseases related to smoking or secondhand smoke, I should say, require more consistent long-term long-term exposure. So if you live with a smoker, whether you're a woman or man for 20 years, the data shows your increased risk of lung cancer and heart disease. of cancers and heart disease. It's not as high as, it's never going to be as high as a smoker, but it's not insignificant. And I don't have the numbers in front of me, so I can't give you actual numbers, but that's kind of the way I would break it down, is sort of chronic exposure versus sort of very short-term intermediate. The thing about housing that I mentioned is that's where the asthma comes into play. So, we know that that kids, it's in New York City, kids who live in a non-smoking home have higher levels of cotinine, which is a measure of being exposed to cigarettes, than people who live in single-family homes who are non-smokers. So that child, if they have asthma, could also be affected by that exposure, actually, even though their home is technically not smoking. But if they live in a building that has pretty leaky walls, which a lot of us live in, if they're not pre-war buildings, that kind of, again, what I'm saying is like that acute exposure can trigger that kind of reaction, like in someone with asthma. There was an interesting study. It was only a one-off study, so I don't know what to make of it, but that heart attacks went down. The city made restaurants smoke-free. Heart attacks went down, and then they reversed it because, I don't know, the politicians were not in favor of it. And suddenly heart attacks went up. And I just had trouble really understanding that data, because you're saying that if someone who has severe heart disease is exposed in a restaurant, for example, to smoke, that's going to trigger a clotting event. That's what the data seem to say. But again, I think you either have to, it's really more likely that it's going to trigger, an asthma attack, or, if someone has COPD, some breathing problem with people who already have some kind of airway issues, because it's irritating the airways. But again, it's unless you're exposed in a chronic way, you're not at increased risk necessarily of chronic diseases. I hope that answers the question. But if not, ask me again.
Okay, and it looks like that's all the questions that came through. So if there's no further questions, I would like to thank Dr. Shelley for all the wonderful information today, all the resources. That was so informative, and we thank you. And Paul, we thank you so much. I'm sorry we couldn't hear you, but we love to collaborate with you. And for anyone who would like more information about GMHC, you can visit their website. It's gmhc.org. They also have a Facebook page with more information. And Paul, thank you again. And sorry we couldn't hear you. And we look forward to working with you.
I just want to thank Paul also for having us, and I'm happy to work more with you guys. I look forward to collaborating if there's an opportunity, and happy to share these slides if I can get your, actually, Rachel, you can, or Megan, you can give me his email address.
Yes, definitely. And as I mentioned, this was recorded, so we'll put it on the Perlmutter Cancer Center YouTube channel. Paul, I will share it with you, so if you can, pass it along to anyone who couldn't make it today. And thank you to everyone who tuned in.
Great.
We'll see you next time. Thank you.